and my teacher, Professor Andrew Boyle. He's consultant cardiologist at John Hunt Hospital. Good afternoon. Let me introduce the next speaker for the day, Professor Andrew Boyle, my teacher. He's from John Hunt Hospital, Newcastle, NSW, Australia. He's going to talk us Chronic Coronary Syndrome, Rational Use of Diagnostic Tools and Therapy. Over to you, Prof.
Hello, and thank you for inviting me to speak at the Sri Lanka College of Cardiology meeting. It's my real pleasure to be here virtually, and I wish I could be there in person in your beautiful country. So thanks for inviting me. Today I'll talk about chronic coronary syndromes. Begin with the epidemiology and go through the pathophysiology of chronic coronary syndromes, assessment of symptoms, and then we'll touch on medical therapies and interventional approaches. And throughout this talk, I'll keep in mind the quote of Sir William Osler: "To prevent disease, to relieve suffering, and to heal the sick, that is our work." And so it is with chronic coronary syndromes. First, the epidemiology. Ischemic heart disease is the number one cause of years of life lost in Sri Lanka. These data from the Global Burden of Disease are specific for Sri Lanka. And if you look on the left column, ischemic heart disease is the number one cause of years of lives lost in 1990. And in the right column, in 2010, 20 years later, it remains the number one cause of years of life lost. And in fact, there's been a 34% increase. You'll notice that stroke, which has a similar pathophysiology to ischemic heart disease, is also one of the major causes of years of life lost. But it's not just about lives lost. It's about disability-adjusted life years, or DALYs. And this graph shows that the number one cause of disability-adjusted life years is ischemic heart disease. You'll notice that diabetes and cirrhosis are rising, but ischemic heart disease remains the number one. So it's a very important disease. The pathophysiology is incompletely understood, but what we know about it is that it's initiated by low-density lipoprotein particles from the serum crossing the endothelial barrier into the intima of the blood vessel. Here, the LDL molecules are oxidized and undergo enzymatic modification, where they become intensely pro-inflammatory, and they activate the endothelium, rendering it more susceptible to more LDL particles crossing, as well as inflammatory cells coming into the intimal space. The oxidized LDL is taken up by macrophages and is accumulated within them, and they evolve into foam cells, which is purely a descriptive term. Down the microscope, all the cholesterol looks fluffy and foamy, but they are actually very intensely pro-inflammatory in that state. And the activated endothelium is more likely to have circulating monocytes attach and transmigrate into the vessel wall, where they become macrophages. These macrophages secrete pro-inflammatory cytokines, chemokines, and proteases, which break down tissue structure and cause intense inflammation. Other inflammatory cells, such as lymphocytes, also adhere to the endothelium and transmigrate into the vessel wall and secrete both pro- and anti-inflammatory cytokines, which lead to a laying down of smooth muscle cells, which causes fibrotic atheromatous plaque, but also has the effect of walling off the inflammatory lipid-rich part of the atheroma. And if we look at these human autopsy cross-sections through coronary arteries, you'll see various stages of coronary artery disease. On the left here, we see a coronary artery with a very large yellowish lipid content. This is LDL, oxidized LDL within macrophages, but it's separated from the lumen by a very thick fibrous cap. This is those smooth muscle cells that have proliferated, and this effectively separates the lipid from the circulating inflammatory cells and platelets and keeps that plaque stable. However, the continued laying down of LDL cholesterol there tends to compress the lumen over time, causing chronic coronary syndromes due to inadequate blood supply to the myocardium. At times, these plaques become inflamed to the point where the inflammation erodes the fibrous cap, exposing the cholesterol within the vessel wall to circulating platelets, and a thrombus forms. There can be hemorrhage into the plaque, as well as thrombus formation in the lumen, and this is the development of acute coronary syndromes. And it's likely that plaques move from stable to unstable and back again numerous times throughout an individual's lifespan, only becoming clinically apparent in the most severe of episodes. So, in addressing chronic coronary syndromes, we want to keep in mind this pathophysiology of lipids followed by inflammation and maintenance of a thick fibrous cap to prevent acute coronary syndromes. Now, assessment of symptoms in chronic coronary syndromes. Diamond and Forrester classically describe three characteristics of angina, and that is retrosternal chest discomfort, classically a heaviness or tightness. It occurs on exertion and it is relieved by rest. That's been in all our textbooks, and I think everyone knows that. If a patient has all three, that's considered typical angina. Any two of those three is atypical angina, and one or none of these characteristics is non-anginal chest pain. Now, this is a very simple classification, but it's very helpful in assessing a patient because it allows us to assess their pre-test of obstructive coronary artery disease. So you can see here that in patients with typical, atypical and non-anginal chest pain, as they age, the risk for obstructive coronary artery disease increases, and it's higher in men than in women in each of these subtypes. So for non-anginal chest pain, in a young woman, the likelihood of obstructive coronary artery disease is very, very low. Whereas in a male who's in his 60s or 70s with typical symptoms, the pretest probability of obstructive coronary artery disease is high. It's likely that that patient presenting with those symptoms has obstructive coronary artery disease and is presenting with a chronic coronary syndrome. And this pretest probability should figure into the evaluation of someone presenting with what might be a chronic coronary syndrome. So this is taken from the most recent European Society of Cardiology guidelines for chronic coronary syndromes. And that was in 2019, published in early 2020. And here's how they recommend we assess patients who might have chronic coronary syndromes. Step one, assess symptoms and perform basic clinical investigations. And if they have an acute coronary syndrome, you rule them out and send them down that pathway. The next thing is to consider comorbidities and quality of life. And that's really to decide if revascularization and medical therapy would help their symptoms or prolong their life. If you think it would, non-invasive tests are the next step with a resting ECG. Consider a chest x-ray and perhaps an echocardiogram. Next, assess their pretest probability and clinical likelihood of coronary artery disease. And if you think it's non-anginal chest pain, then go and investigate and treat for that. But based on the Diamond and Forrester classification of angina, as well as other clinical parameters, this is the recommended way to take it to the next step. If the pretest probability is very low, no testing is recommended. If their pretest probability of obstructive coronary artery disease is low to intermediate, a coronary CT angiogram is a recommended first test of choice, if it's available and if there is local expertise. And as the clinical risk or the pretest probability of obstructive coronary artery disease increases, then testing for ischemia becomes the preferred next step. And that could be exercise ECG stress tests, it could be stress echocardiography, it could be nuclear perfusion studies, or even stress MRI, depending on what's available and the local expertise. And in patients in whom the risk is very high, it's reasonable to proceed straight to invasive angiography and consideration of invasive physiology imaging, invasive physiological assessment at the time. So really, the pre-test probability of obstructive coronary artery disease guides the next step in testing for patients presenting with chronic coronary syndromes. And then after this testing is done, choose the appropriate therapy based on symptoms and risk of acute coronary events. This slide further delineates who should have what testing, and coronary CTA is preferred if there's a low clinical likelihood of coronary artery disease or obstructive coronary artery disease. If the patient characteristics suggest a high quality image, so someone who has a low heart rate or is able to be beta blocked to a low heart rate, does not have atrial fibrillation or frequent ectopy, which renders some of the images prone to artifacts, as long as there's local expertise and availability of the scans. And it can also give you information on atherosclerosis, whether it's obstructive or not, and the decision to treat that before it becomes obstructive. It's best in patients with no history of coronary artery disease because it's very helpful in telling the presence or absence of disease, but less so in the extent of narrowing. Whereas non-invasive testing for ischemia with stress testing is preferred in those with a high clinical likelihood of obstructive coronary artery disease, particularly if you think you'll revascularise them. It can also help with viability assessments. So based on either of these, you may initiate drug therapy or consider going on to invasive assessment. And that's typically for people who have high clinical likelihoods of disease or symptoms refractory to medical therapy, or those who get typical angina at low exercise on the stress test, or if they have regional LV dysfunctions suggestive of coronary disease. And at angiogram with very tight stenosis, it's reasonable to revascularise, or you may do a functional assessment with a flow wire and then go on to medical therapy or indeed revascularisation. So moving on to treatment of coronary syndromes, there are a number of options. And I think the aims of treating chronic coronary syndrome should be fourfold. Firstly, to prevent or at least slow the progression of plaque buildup. And this will have the effect of preventing angina, preventing the need for stents, and preventing the need for bypass. To prevent or at least delay the development of acute coronary syndromes. Prevent heart attacks, prevent long-term myocardial damage, to improve patient symptoms, and to prolong life. And keeping in mind that quote from William Osler, this is the work we do. So let's start on the medical therapies. What do we do to prevent progression of plaque buildup? Well, obviously, lipid lowering is the cornerstone of this. And the guidelines recommend statin therapy, class 1 indication, level of evidence A, in all patients with chronic coronary syndromes. And if the patient's goal is not achieved with a maximum tolerated dose of statin, add a combination with ezetimibe. And for patients who don't achieve their goal on maximum tolerated statin or ezetimibe, or are completely intolerant of those drugs, PCSK9 inhibitor is recommended. And those are backed by high levels of evidence with a class 1 recommendation. Other things which may prevent progression, ACE inhibitors, and there's conflicting data on this, but if there's another reason for ACE inhibitors such as diabetes or LV dysfunction, then it's quite reasonable to introduce one. Or if you think the patient is at very high risk of acute cardiovascular events, then you could add an ACE inhibitor with a 2A indication. Beta blockers could be considered. I think this is an important practice point. In the most recent ESC guidelines, the LDL target is lower than it has been before. In the past, it was 1.8 millimoles per litre, and in the most recent guidelines, that's been lowered to 1.4 millimoles per litre. And further, A goal of 1 millimole per litre may be considered in patients who experience a second vascular event within 2 years, whilst on maximum tolerated statins. So these are very aggressive lipid targets now, and it's difficult to achieve 1.4 millimoles per litre with statins alone. Certainly in my practice it is. And so with that in mind, there's going to be a lot more PCSK9 inhibitors prescribed, and the cost of that is going to be substantial. So the second goal of therapy in chronic coronary syndromes is to prevent acute coronary syndromes. The cornerstone here is antiplatelet therapy, but also remembering that the anti-inflammatory effects of statins also prevent thinning of the fibrous cap of a plaque and prevent plaque rupture. So statins not only prevent build-up of LDL, they also prevent acute coronary syndromes. When it comes to antiplatelet agents, I took a clip of the latest guidelines on the right. You're not supposed to be able to read that. It's just to show how complicated antiplatelet therapy regimens have become. In general, a single antiplatelet therapy is indicated for all patients with chronic coronary syndromes. That has traditionally been aspirin, but clopidogrel has shown to be equivalent in this situation and could easily be substituted for aspirin. It's quite cheap, it's off patent, and it has less GI upset. If a patient requires an oral anticoagulant, the non-vitamin K oral anticoagulants are better than vitamin K antagonists in patients with chronic coronary artery disease. If there's a requirement for an oral anticoagulant, you can add an antiplatelet on top of this if the patient has had a previous MI, high risk of recurrent ACS and low bleeding risk. But in general, an oral anticoagulant alone in chronic coronary syndromes can suffice. You can also consider the other antiplatelet agents such as prasugrel or ticagrelor. They have lower levels of evidence in chronic coronary syndromes, but they do have some evidence in patients who had previous ACS and are stabilised. So that's my summary of a very complex area, something we could talk for hours about. But I think in stable coronary syndromes, it's usually a single antiplatelet agent with your choice of either aspirin or clopidogrel. What about anti-inflammatories? Well, this is an area of intense investigation in the research world at the moment. Inflammation is such an integral part of the development of atherosclerosis, but also in the transformation from stable to unstable plaques. Canakinumab is a monoclonal antibody which is shown to reduce the rate of acute coronary syndromes in patients who've had a previous MI, but it's very expensive. It's not on the market yet, but it may come, or some other anti-inflammatories. Colchicine is an old and cheap anti-inflammatory. It's been tried in a number of post-ACS populations. There have been conflicting results with that, but by and large it probably helps stabilise plaques in acute coronary syndromes, but there's no role for these anti-inflammatories yet in chronic coronary syndromes. So I think we'll see them come into the guidelines in the coming years for post-ACS situations. Okay, the third aim of medical therapies should be to improve symptoms. As doctors, we don't just save lives, we try to make people's lives better. So this is a slide of how to approach anti-anginal therapy in chronic coronary syndromes from the most recent guidelines. So if we look to the left of this, in standard therapy, the first step should be a beta blocker or a calcium channel blocker. And that would be a non-dihydropyridine calcium channel blocker such as verapamil or diltiazem. Our second step would be to add a dihydropyridine calcium channel blocker. And if the combination of those two is not enough to reduce angina to an acceptable level for quality of life, we could add a second-line drug. Now, beta blockade should aim for a heart rate of 55 to 60 beats per minute at rest, according to the guidelines. And what are these second-line drugs? These include long-acting nitrates, nicorandil, ranolazine, and trimetazidine. Now, there are certain situations where you might choose one drug over another, and not the standard situation. So for patients who are particularly tachycardic, then a beta blocker or a non-dihydropyridine calcium channel blocker or both. And then the next step would be to add ivabradine, which can slow the heart rate. Conversely, people who have a low heart rate to begin with, you might start with the dihydropyridine calcium channel blocker, which won't drop the heart rate and may even cause a reflex increase in heart rate. You may try a long-acting nitrate or a combination thereof. Now, patients with LV dysfunction or heart failure, you'd want a heart failure beta blocker. And then you might add nitrates, which can be effective in heart failure, or ivabradine, which has one clinical trial showing beneficial outcomes in heart failure, or any of the second-line drugs. And for those with low blood pressure, you might want to be on one of the second-line drugs a little bit earlier. Okay, if the medical therapies are not enough to control symptoms and improve quality of life, then we move on to intervention. PCI versus CABG is another talk in and of itself. For stable coronary artery disease, we've traditionally used percutaneous coronary intervention, particularly with drug-eluting stents, in straightforward, easily stentable coronary lesions. And coronary artery bypass graft surgery has been reserved for the more complicated anatomy, but also in patients with LV dysfunction and in diabetics in particular. The debate between them should not really centre on which one is better, but they should be considered as complementary tools to improve symptoms and improve outcomes. And in particular subsets, bypass surgery improves outcomes more than PCI, such as in diabetics and triple vessel disease with left ventricular dysfunction. And the continued debate and differing outcomes in clinical trials underscores the importance of a heart team meeting approach, where the patient's interest should be first and foremost, and bypass surgery versus PCI should be considered for symptom control and prognosis in the appropriate patients. And just this week at the American Heart Association, there was another study which looked at PCI versus CABG in patients with left main disease. So symptomatic patients with left main disease have traditionally been the purview of cardiac surgeons with bypass surgery, and 4 large clinical trials have had conflicting results in comparing PCI to CABG. This is an individual patient-level data meta-analysis from those 4 trials, where not the overall trial result, but the individual patient results were compared. This is left main stenting versus bypass, and it's over a period of 5 years. And there doesn't appear to be a difference in mortality over that time. Perhaps an early excess in the CABG over PCI with the catch-up phenomenon, but the curves are really quite parallel and not significantly different at 5 years. But if you look at other outcomes, there is an excess of spontaneous myocardial infarction in the PCI group, a doubling, whereas there's either the same or less in periprocedural MIs. The rate of stroke is lower earlier in the PCI group with a catch-up phenomenon, but repeat revascularization, the Achilles heel of stenting, is higher in PCI. So when presented with an individual with a chronic coronary syndrome in whom we're trying to alleviate symptoms, we've got to take into account the patient and the physician's weighting of how important these outcomes are. Is non-fatal MR really important to you? Is early stroke risk important? And what about mortality? And so this underscores the importance for an individualised or tailored approach to each patient when considering interventional approaches to symptom control in chronic coronary syndromes. So in summary, chronic coronary syndromes are common. They result in death and disability more than any other disease. That's true throughout most of the world, and it's particularly true in Sri Lanka. It's distressing that we're not seeing a decrease in this, but we've seen a 34% increase over the last 20 years. The pathophysiology involves lipid deposition, which incites inflammation, and these processes go on to lead to progressive coronary artery narrowing and acute coronary syndromes. Therapy should aim to prevent progression of plaque to prevent acute coronary syndromes, to improve symptoms, and to prolong life. And with that, I'll finish my presentation. Thanks very much for your attention. Sorry I couldn't be there in person, but please feel free to email me if you have any questions or comments. Thanks very much.
Thank you, Professor Boyle, for that very informative lecture. On behalf of Sri Lanka College of Cardiology, once again, I thank you for joining us virtually and presenting that interesting lecture. And as it's a plenary, we don't entertain any questions, and so we'll move on to the next item in the sessions.